day when the issues with the documentations have been sorted out. So we will interpose Dr. Magan in the interim. Sir, do you have an objection to taking the oath, or? No objection. All right, thank you. So will you then say after me, I, and your full names?
I, Avesh Jagdish Magan,
Swear that the evidence that I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you. So, Dr. Megan, we have received your complaint and a response from Discovery. So you can take it that we are familiar with the essential facts of the matter, but you can take us through the situation as you see it. And if you have any responses to give to what Discovery has said, also give us those responses.
Proceed. I'd just like to find out, have we received any response from Medscheme?
Was it not given to, because the response of Discovery should have been given to you?
I have the response from Discovery. I'm just inquiring about the response from Medscheme. My complaints were twofold, one against Discovery and a second against Medscheme.
All right, we will have a look at the whether or not it was delivered, but I can't tell you now. But let's use the time, Dr. Megan, for now.
Right. With regards to the response from Discovery,
Dr. Magan, perhaps you can just start by introducing yourself and explaining a bit about your practice.
Right.
I think that's always an appropriate place to start, so we understand how you work and how you work with the schemes, and then perhaps go on to onto the specific scheme responses.
Thanks very much for this opportunity. I'm a specialist orthopedic surgeon, and my practice at the time of the audit was situated in Mthatha in the former Transkei. At the time, I had two practices at Life Queenstown Private Hospitals in the former Ciskei, and Life St. Mary's Private in the former Transkei, based in Mthatha. So I had two practices concurrently in both Queenstown and Mthatha, 240 kilometers apart. Historically, I was the first South African board-certified orthopedic surgeons to start practicing my specialty of orthopedic surgery in the former Transkei and the former Ciskei, both in Life Healthcare Institutes, and I began my practice in 2012. The nature of the practice is that it obviously has a very large catchment area that starts from Kokstad on the KZN border and terminates in East London in the Eastern Cape. So we're looking at around a 400 to 500 kilometer radius, and far interior as Aliwal North, going towards the Maluti Mountains. So a fairly large part of the Eastern Cape, being the only, at the time, the only South African orthopedic surgeon in a vast territory. So that is the nature of the practice. The practice was based on the fact that being the only orthopedic surgeon, I did have attended to emergencies and elective work, and at most times the emergencies would supersede the elective work. The realm of pathologies were vast, and because of the nature of the territory, there's a huge amount of interposition of socioeconomic factors taking place, interwoven with pathology, and it hence made practice very challenging in an area of absolute need.
Yes, thank you. You can just take us through, thanks for that description, in relation to the genesis of the complaint.
Okay. So the complaints actually started with regards to discovery per se. 17th of April 2018, I received a letter from Discovery requesting the copies of clinical notes and patient information, theatre notes, etc. I'm sure you've perused those requests. And so at the time I requested, I've got sought legal advice from an MPS representative, Advocate Ngcukaitobi van Vuren, who accompanied me to a meeting at Discovery's head offices on the 10th of May. It was a meeting that took place, and the people that were, I think, Advocate Altus van Rensburg did submit his affidavit as well.
Dr. McGann, in our bundle, or the documents that you've provided the panel with, the correspondence begins at the 4th of February 2019, page 851 of the bundle. You're now referring to 17th of April 2018. Where is that in the bundle of documents that you provided us with as part of your complaint?
Sorry, which page did you mention?
So, the complaints we are aware of, the first letter from Discovery is at 851.
851, all right. All right, that's correct. Yeah.
And just to orientate you in the bundle, then at 918 is your recent correspondence to the panel on the 4th of September 2019.
That's correct, yeah.
Okay. And there's a number of other pages which it's hard to follow the chronology, but then now at 941 is Discovery's response, and that gives you a bit of orientation in the bundle.
Right.
Just be aware that's all we have in front of us, and that is all we've read.
Okay. Thanks. I've perused the documents that Discovery had, basically Discovery's response to our letters of complaint. You'd obviously want my interpretation of that or my thoughts on that.
You see, what would help is if you just take us through step by step.
Right.
Don't start at the end, start at the beginning. You know, what your experience was in dealing with Discovery and what the impact of their response was. And you can also do the same thing in relation to Medscheme.
Okay, all right. So I'm not going to follow this. Can I just speak?
Yes, please.
Sure. My experience with the Discovery was that they initially had suspended my account upon starting the audit. And they'd given me a strict guidelines into terms of when I could hand through the documents. And my legal advice at the time said, wanted us to have a meeting with Discovery. And so Discovery had agreed at the panel. The person that I was liaising with was Dr. Nash Pillay. And we had gone through Discovery's offices and to have a meeting regarding various things that we thought were not correct.
Dr. McGann, what
Yes.
year are we in?
We're in 2018.
Okay, so this is after you received this letter in 2018, not 2019.
No, absolutely, 2018.
Okay.
And the meeting was on 10 May
That-
2018
2018, that's
with
correct.
Discovery
With Discovery
in Sandton.
in Sandton.
And with whom did you meet?
I met with Dr. Nash Pillay. I've met with the head of forensics are, it's detailed, the people that were present at that meeting, it's in the bundle. And a clinical coding specialist was present, my attorney, which was Advocate Janssen van Rensburg, and myself.
Yeah.
Thank you.
So may I ask, is it correct that all these documents that you are referring to are in Discovery's affidavit, not in the documents you provided us with?
No, I did provide that as well. It was emailed through to the investigative panel.
It certainly is not in our bundle. It's now in the Discovery affidavits, but it's not in the bundle of documents that we receive from you unless there's been an administrative mistake.
Not your administrative mistake, so carry on.
All right. If I may, there's certain issues that I would like to discuss. I would like to make use of this opportunity and to discuss the points that, or to succinctly go through the points that I would like to give you here in person from that meeting. So I've perused the response from Discovery, and there are lots of information that was not in that response from Discovery that I would like to be given the platform to discuss. That was...
This is your platform, so
All right.
go through it. Yeah.
Thanks very much for that, Advocate. In the issues that we've had with Discovery and are many, so I'll take it from the very first thing. Yes, we are aware of the legalities or the interpretation of Section 59 regarding the confidentiality of patients, the contents of patients' clinical notes, theatre notes, hospital notes, etc. And both the advocate representing me and the advocate representing Discovery at the time agreed to not to agree regarding the different interpretations of that, where Discovery were quite vehement that any member gives their right to have their information disclosed upon request. Advocate van Rensburg was in complete disagreement of that. That was the first thing. We then agreed to, I'd come through with a bunch of patients' files. I had about 30 patients' files at the time. It's important to note that we'd only discussed 2 patients' files at that particular meeting before our time had run out, our 2 hours had run out. So what was discussed at that meeting was firstly the concept of outliers, which I was told that I was at the time. And I did discuss upon them the nature of the practice, that it was not an usual practice. It was a practice that was, I had 2 concurrent practices, 240 kilometers apart, covering a vast area of the country. The pathologies that were present was certainly that were pathogenomic of patients that were obviously with socioeconomic neglect and were very challenged. Most of my patients were immunocompromised, not necessarily from HIV, but immunocompromised. So from that perspective, we didn't home down on the fact that we haven't established who the peers were. Discovery kept referencing my practice to peers, and to this date, I don't know who they are. I'm not sure where they get their information from. Who are they cross-referencing the pathologies that I did treat at the time? Which practices? To this date, we have not been furnished with that details or information. With regards to the pathologies or the codes that were discussed, and this was my biggest bone of contention, if you mind the pun, is that Discovery had a nurse in present who called herself a coding specialist. And my question was in our roundtable discussion is, what is a coding specialist? I up to now have no idea what that is. It took me 17 years of post-matric training and qualifications in tertiary and board exams to get to practice what I do, to appreciate the pathology that I treat, and hence a full appreciation of the codes that I'm allowed to use in treating the pathology. Yet I'm meant to sit at a table with an ex-nurse with possibly a 3-year qualification to discuss pathology or operations of extreme sophistication. So I find that I found that extremely unfair. I would hesitantly use the word unlawful, but I find that extremely unfair that there was no peer review taking place at this particular meeting. I'd hoped that there'd been a peer in the sense of another orthopedic surgeon in full-time private practice who at the time do see patients who have inherent pathologies that I was treating at the time. But the only peers, inverted commas, available was a general practitioner who admittedly had not seen the operation that we're going to discuss, was not involved or assisted in the surgery that we're going to discuss, and a nurse who called herself a coding specialist. So I found that very unfair, to having to discuss details and having to motivate why certain procedures were done, why the use of codes that were used to people who have never been involved in such complex surgeries or operations. So I found that to be extremely unfair.
Just tell me, I'm trying to follow there is a document at page 918, which is dated the 4th of September.
Right.
That seems to come from an attorney.
Right, that 918 is my documentation, it's my affidavit.
Now that contains the minutes or the notes of what transpired at the meeting with Discovery
That's correct.
On the 10th
That was my summary.
on the 10th of May.
10th of May, that's correct.
Was that ever given to Discovery? Did they ever confirm that those indeed were item number 1 of that meeting, the one you've just spoken about, says that Discovery admitted that they didn't have case managers in rural areas that verify management of patients, claims and authenticity of admissions, treatment plans, and
Well,
surgical outcomes.
that I'm sure will be at the minutes that with Discovery. That meeting was held, and it's also documented in my attorney who was present at the time. So we'd had this meeting with Discovery, and they had agreed to have a follow-up meeting, which they didn't. All we received was the amount that needed to be clawed back. That was the only communication that we had from Discovery at the time. There are lots of things that that's why I'm in response to my response to Discovery's response of the documents that was recently submitted. There's lots of information there that was not present in the response recently that Discovery had sent through to the investigative panel. Hence, I'm using this platform now to discuss those intricacies that was discussed at that meeting that are not present in Discovery's response.
That's fine. I'll come back to that.
Okay.
And the second item is they admitted that they don't have software in place to refute a claim within the 30 days.
Absolutely.
Yeah.
So the coding specialist, she was a nurse at the time, and a very approachable lady, and she admitted that in accordance to Section 30, where a scheme has got 30 days to query a claim or to refute a claim or an invoice, they didn't have the software, or even up to now, don't have the software to pick up anomalies in invoices, to have it questioned within the 30-day format, as governed by Section 30. So she agreed to that they don't have the software at the time. So there are lots of things that were discussed at that roundtable in Discovery that the lawyer who wrote the response didn't mention, and hence I'll use this platform to go over those information that was absolutely pertinent to what we are today, not present in his response.
Is it not, though, that that might be the case, that there isn't the software to pick up an anomaly within 30 days?
Right.
The response to that may be that it's given the number of claims that are processed on a daily basis by the schemes, by Discovery. Let's just take Discovery. It's impossible to be able to detect an anomaly within the tight time frame that the Act requires the scheme to make payment, which is why they are entitled under Section 59 to claim back amounts that they show have not been, you've been paid to which you were not entitled, right? So that's really the area we are in. It's not the 30 days, it's once the scheme has identified that there's been a payment that's been made to which the practitioner is not entitled to be able to recover that amount.
Okay, I'm glad you brought that point up. With all due respect, it is the duty of the funder to pick up such anomalies early enough, to have engaged with a doctor like myself to say, we have noticed that certain codes are incompatible. Because remember, who chooses the codes? A medical funder cannot be prescriptive as to what codes ought to be compatible for a particular ICD-10 code. It is the clinician such as myself who deals with a patient, who understands the pathology, and then chooses judiciously as to which code he can or cannot use. Now, if Discovery, or any funder for that time, thinks that this particular code should not be compatible, then it is the onus of the medical funder to engage the doctor early on, at the quickest possible time, to say, these codes cannot be used, these are the reasons why they're not compatible. I was subjected to a 5-year retrospective analysis, and I think it's terribly unfair for a young surgeon aged 35 in an area that is challenged to be all alone, to go through a process, seeing challenging patients, submit claims where my College of Orthopedic Surgeons did not guide us as to what codes we can use. It's up to me, to my discretionary interpretation, as to which codes are applicable to the pathologies being addressed. It is the funder's obviously choice as to whether these codes are acceptable for funding. But surely that must occur quickly. It must take, if you say 30 days, well, perhaps 60 days then, perhaps 90 days. 5-year retrospective analysis of those codes is terribly unfair. Because, but then, who's entitled to correct a billing behavior? Who is meant to say, these are the required codes? Whose duty is that? Is it the Health Professionals Council? Is it the South African Orthopedic Association's duty to tell a young surgeon, doctor, these are the prescriptive codes or the suggested codes that can be used? Whose duty is that, Advocate? Would you mind enlightening me?
Dr. McGann, can I
Yes.
ask you a question? You might have to look at your bundle just to follow my question. But as my colleague has pointed out at page 920 of the bundle, that's your submission.
That's correct. That
There
is my submission.
There is this record of your concern that the use of clinical codes ought to be peer-reviewed by an orthopedic surgeon in private practice.
Absolutely.
So that's your position. Discovery, or I shouldn't say Discovery, rather the National Health Association has also given evidence on this, and they suggested that it wasn't possible in this type of speciality to have this type of peer review because there aren't enough orthopedic surgeons to do so.
I totally disagree with
I
that.
can hear that. So then if I can take you to 975 of the bundle. Now this is the minute of the meeting that went it's the minute of the meeting that took place on the 10th of May 2018 as well, and now this is Discovery's minute.
Right.
So if you hold your finger on 920, you've got a description of
Sorry,
what
page 920.
920 is yours, and
Right.
and 974
974.
is Discovery's.
Right.
So if you turn over to 975
Right.
under the heading that says decisions taken, I'll read it verbatim. It says 15 cases reviewed. Those are 15 of your cases were reviewed with all our information, that's Discovery's information, to be forwarded to Dr. Magan to provide additional clinical information should he wish to do so, whereafter information will be forwarded to the Orthopedic Society for an opinion.
Well, this is the first time I'm seeing this, Advocate. I received no such communication from Discovery. Neither did my advocate. Receive such information. You can contact him to verify that. That means Advocate Janse van Rensburg and myself, have received no such evidence of this communication from Discovery. We were obliged to do so.
Can I ask, is it a correct recordal of the decisions taken in the meeting?
No such this decision making by Discovery was certainly not discussed with us at our roundtable discussion. Neither was it put in writing, and neither do we have Advocate van Rensburg's
Is that the document at 974?
975 Advocate.
975, but go to 976.
Right.
And at the bottom, at item 10, confirmation of the record. And then the undersigned part is that's the provider, which presumably is yourself, and that's Discovery. Both of you seem to have signed.
Yes, but I'm not sure if it's contemporaneous enough because this writing in handwriting, I've never seen before. How do we verify whether it's contemporaneous?
Dr. Magan, is that your signature on page 976?
It is my signature.
So then how can you say that you didn't?
No, but I can certainly have not seen this communication from Discovery because I would gladly have met with South African Orthopedic Association.
So you've seen this document?
I've seen this document on
You've
976.
seen this handwriting on page 975?
No, I've not seen a handwriting 975. This is my signature on 976. I have not, and I swear under oath, have not seen this writing on 975.
Did you initial page 975?
I don't see I don't see my signature there.
974 is initial, 975 is initial, 976 is signed, and all of that is under oath. Anyway. Yes,
But I would have
continue.
gladly compiled if I'd seen this, or neither would my advocates have mentioned this.
The issue with the codes
Right.
is, so we've heard quite a lot on the codes at the beginning of our investigation and the complexities
Right.
and the different manuals, the different coding manuals and so on. But what appears to be the case here is that whether it's as a result of the coding, well, it appears to be as a result of the coding, the cost of your claims were significantly higher than the norm. In some cases, almost 300% higher than the norm.
For these patients mentioned, notwithstanding the thousands of patients that have not been mentioned. So
Okay, but do you agree that it was
I agree.
I mean, that's not just...
I agree, advocates, that in these particular individual patients, due to the complexity of the pathology, it's certainly high than within my own practice. If I have to compare the
You're
other
saying it
1,000
was
patients.
the high claim in that case was justified because of the complexity of the case.
If we take each patient individually and look at it individually, these are complex pathologies. If you are to compare myself with reason, that if you look at my coding, my ability to practice or my ability to code over a period, over a graph of 5,000 of my own patients, you'd find that on patients where they have mild pathology, the coding is within the norm or even below the norm. Yet for patients with complex pathology, it's certainly going to be higher. So if you look at the ability to use coding, we are looking at a small sample size. I'm looking at a 10,000 patient file, 10,000 patients, or even particularly if you look at Discovery, there's hundreds of patients. We have to look at it in perspective of over all patients being billed. Patients who have got pathology, we have to treat each pathology individually, each patient individually. And that's where I have the biggest issue here. You cannot look at pathologies as coding, then extrapolate codes used over a period of 10 years and compare that as a percentage over a national average. That's terribly unfair. Each human being is unique. Each pathology is unique. No gunshot wound is the same to any individual. It cannot be the same. That is why each patient has to be peer-reviewed individually, not being grouped as a percentage over a period of 6 cases. What is the cost for doing that? It's okay if you're doing a desktop audit sitting in a beautiful building in Gauteng, yet I am dealing with patients far, far away in a rural area with massive amounts of pathology. Hence my question, advocate, where were the Discovery case managers? So my colleagues in Johannesburg, Pretoria, Durban, and Cape Town are blessed to have Discovery case managers walk into the wards, greet the patients, tell them who they are, and assist in working together symbiotically so that for the best interest of the patient, as Discovery puts it. Yet, why was I not privileged to have a case manager? These 5 patients or 20 patients had complex pathology, long patient stay. Where was the Discovery manager at the time?
These were surgeries, so there would need to be pre-authorization from the scheme.
No, it had to be, these were patients admitted via an emergency department. So they'd come into hospital. My officers don't pre-authorize. It is the case managers employed by the institute who then have to liaise with case managers from the medical schemes to update on codes. Now, who are the case managers? Are they nurses? Are they doctors? Or are they specialists? 99% of the time, case managers are nurses who do not communicate with doctors at all. My question is, if Discovery had seen these were high-paying costs, high costs to their scheme, was it not their duty to send a case manager out whilst the patient is there? To then have her engage with me, say, doctor, why are you doing 3 operations on this particular gunshot? What is the need? Can we look at that wound? As my colleagues do in the bigger cities, case managers come in, when the wound is exposed, they get to see the tendons there. They get to see the bones that are fractured. They get to see the immunocompromise of the patient, the weak, emaciated, unresuscitated state of the patient. And yet, it's easy for them to update to the scheme at head office exactly the pathology is being determined. Why must I, in an area of need, not have the privilege of a case manager from Discovery coming to say, Dr. Magan, can we engage with you regarding your complex patients, your patients who have no access to running water, no access to electricity, yet they are medically insured. 60% of our country have no access to these amenities, yet a lot of them are medically insured. Most of my patients who lived in Mthatha and the former Sky are medically insured, but still, to this date, have no access to an inside toilet, running water, or ablution facilities that you and I enjoy. It is the same neglect that the medical aides do not send a medical advisor to the hospital or to my practice to help each other. Here I am, and alone, a young surgeon in a difficult area that's challenged, yet no help from Discovery, no guidance from the various organizations, yet I'm, in a young 35-year-old, has to make informed decisions as to the best interest of my patients, that the scheme suddenly forgets. These are their members that they have the best interest in, but they don't care to send a representative to see what's best for the patient.
So you said that there were 2 patient files that you managed to get through in the meeting with Discovery.
No, out of 30, we only managed to discuss
you managed
2
to
of
get
those.
2.
That's correct.
Right.
In those
and
2
what
hours.
was the outcome of the review of the 2 patient files?
We were in total disagreement. We agreed on certain things. What we agreed on, that yes, Discovery failed to send a case manager out, and if I were to quote Discovery, we are still working on sending case managers to areas of need, or remote areas, or rural areas. To this date, it still has not taken
But
place.
sorry, Dr. Megan, I hear you and I hear your frustration. My question is, what was the outcome of those 2 patient reviews?
Dear Advocate, I'm saying that the outcome was that we have not concluded any finality regarding resolution of those patients. We'd only discussed 2. We agreed to take this matter further. We had presented what we had to present. Discovery was meant to come back to us regarding an amicable solution. All we got was an amount that needed to be clawed back. That was all the communication that I received. So we had not received a finalization or an amicable solution to the contents being discussed at that particular meeting.
Was there any solution?
No solution.
there was
no solution, apart from the respondents I got in writing via email that a certain percentage had to be clawed back. And you've got that in writing why.
And that's what you agreed to pay back?
Well, I had no choice. Well, we're still going to get to that matter. I mean, I subsequently left the region due to, we'll discuss that in detail, but I subsequently left. I was forced to leave a region that I was passionate about. I trained there. I worked there. I served the community there. I was forced to leave due to the duress that I had suffered. Currently, I'm not sure where my patients are. I still receive phone calls asking me to return to provide the service. And during this time, as noted in my affidavits, patients were indebted to the service that they received. They were grateful for the outcomes of the surgeries. And I still maintain a relationship with my patients. I have no relationship with medical schemes. I have relationships with my patients.
One of the reasons for you say it justifies the high cost of your claims was the complexity of the cases.
For those individual cases.
For those individual
yes,
cases.
for those cases mentioned.
And that was complicated, for example, by your patients being HIV positive.
No. That was misinterpreted. I said immunocompromised. HIV is one cause of immunocompromise, of one form of immunocompromise. There are lots of others.
So were you able to show in respect of those patients that they were immunocompromised, even if it wasn't as a result of HIV.
Absolutely, and those are clinical information. I had mentioned that in the meeting to the doctors present, that as a surgeon, by looking at handling delicate tissue, you know that a patient is immunocompromised. By looking at the quality of the bone, the quality of the blood, the quality of the serous fluid, quality of tendon structure, these are clinical things. Remember, not all patients agree to voluntary counseling and testing. Not all patients. Remember, we're dealing with a very sensitive rural community where it is still up to this date very taboo, and not many patients would agree for VCT. But as a clinician, I have a right to manage my patient holistically to the best of my ability. Even patients will not tell me, doctor, I don't want to be tested, but you manage me symptomatically or clinically. And so these are clinical findings, doctor. I mean, advocate. These are clinical findings.
And are they contained in the clinical notes?
Absolutely.
So you provided the clinical notes?
The clinical notes are all present in my surgical notes that I have in those files. We had 30 files present. We only got through 20. I only got to 2. What's most importantly, advocate, which I said that the most important factor here is the patient, the member. No one spoke to the member. When you're doing an audit, I think it's pertinent in my professional capacity as a specialist orthopedic surgeon. If you're doing an audit and the audit contains patients, human beings, please contact them, talk to them, manage them, see where they're living, go to their houses, look at their pathology, look at the conditions, the clinical. We're dealing with people, human beings here, not files in an office, not things on a shelf, human beings with emotions.
But you did not provide the clinical notes to Discovery in order for them to
We had agreed that they
verify
were we agreed that they were allowed to ask generic questions on clinical aspects, but I had the files present on the table, all 30 of them at the time. We only got through 2 of them. I have them ready. They were there at the time. They were there. They were all available.
So how do you propose? I mean, it's necessary for Discovery to be able to inquire and investigate cases where
Absolutely.
before they take any action, they need to check.
I think the manner.
How are they supposed to establish
Right.
whether the claim is
Thank you
a
very
legitimate
much.
claim or
Thank
not?
you very much for asking that wonderful question. This is how it's supposed to be, and this is what takes place in other parts of the country. A patient gets admitted to a hospital. There is a case manager that's present or can either be sent through to verify the justification of a patient being admitted. So if the patient comes from a doctor's rooms, authorization is requested, a case manager can verify, yes, this patient has got a fracture, yes, this patient has got an X-ray report containing the pathology present, and when the patient goes to theatre, there is a comparison between the hospital files and the surgeon's files that a particular pathology has been attended, in conjunction with a case manager from the funder being present in the hospital at the time. And that is the norm in the country. That's the way it is. And in that way, you can be sure that no patient gets to operated without particular pathology. Remember, as I've mentioned in my affidavit,
Dr. McGann, must that case manager be an orthopedic surgeon?
the case manager, not necessarily. The case manager can be anybody. If the scheme deems right that the case manager needs to be an orthopedic surgeon, that's up to the scheme. But this is how it's currently taking place in the country, and this is what.
So why is it not appropriate for the scheme then to use GPs to give views on coding in relation to orthopedic surgery?
It's because if we're just discussing the use of coding for a particular type of surgery, how would a GP be involved in discussion?
Coding seems much more innocuous than giving some kind of clinical decision as a case manager.
The case manager is not there to give a clinical decision. The case manager is there to verify that the patient is indeed there in person.
Verification involves clinical judgment. It does seem like a rather unusual proposal you're making to suggest medical schemes.
No. Please don't misquote me. I didn't say that. I said if you're doing an audit and you're discussing complex pathology, it's best to be peer reviewed. And this was vehemently echoed by the president of the South African Medical Association as well. That if you're dealing with specialists and you're discussing intricate matters that are surgically inclined, it has to be peer reviewed.
Let me perhaps explain my question here. I certainly read, if you turn to 975 of the bundle again, and this minutes of the meeting that took place, I certainly read discovery as offering you an olive branch in this meeting by offering that you submit your clinical information, and then they offered to refer it to the Orthopedic Society.
Well, just to reiterate, I never received this communication. If I had at the time, or was it,
No,
or,
we have heard that, thank you.
or even if they had presented to me at the round table, I would have certainly accepted that, because I have, in my own accordance, I have engaged with the president of the South African Orthopedic Association, and remember, I'm a member of various committees of the South African Orthopedic Association.
So, Dr. Magan, let me just, on this topic, I'll put you something I don't understand. So, in that note that you prepared, which is at page 920,
Right.
so there were 3 items that you put there. So there is the case manager issue, the software issue. Then on this particular issue about whether a GP suffices or a specialist is necessary, it's item 3,
Right.
where you say the general practitioner, Dr. Pillay, tasked to interpret the use of codes for surgical events, had no knowledge of the nuances of the type of surgery performed. Now, if we start there, say that they have no knowledge of the nuances of the type of surgery
Right.
performed. Now, isn't that why at page 975, because at that meeting it's agreed that there is a concern about Dr. Pillay,
Right.
isn't that why at page 975 they then offer you a specialist?
Absolutely. I wished I was given that at the time, on the 10th of May. If that been suggested, I would have gladly accepted that. I would have gladly accepted to sit with a peer and discuss it to the absolute detail. Gladly. It was certainly not offered, and I'm sure my legal representative at the time would bear testimony to that as well.
I mean, I should probably just put this to you, because the note at 975, there are 2 possibilities. If you accept the signature at 975, and you deny the initials at 975, then you are alleging that Discovery has forged this document.
I'm saying that it's the first time that I'm seeing this. I'm not alleging that they've forged the document.
It is impossible that you're saying it for the first time, because you signed it on the 10th of May. It's impossible that you could have signed 976 without the previous 2 documents. You would have been signing just a piece of paper with no meaning, because what you signed at 975 is a confirmation of the record, and the record is 974 and 975. So what I'm putting to you is that it's very unlikely that this document was manufactured, and there could be a fair accusation that you are lying to this commission.
No, I've sworn on the oath that the information that I've now been presented it's certainly the truth. I don't ever remember reading this information, because my request from the word go was to have it peer reviewed. It was certainly my request. Had this been given to us at the time, my legal advocate would have certainly encouraged me to do so. But I mean, we can certainly, if you look at his affidavit, he doesn't mention that as well. If you look at Advocate Altus van Rensburg, he also in his affidavit did not mention that an opportunity was given to us for me to present this to the South African Orthopedic Association.
I'm looking for the affidavit from your advocate. What page is this?
I think it's 914.
914.
913 and 914.
913.
914 and 915. So 913 to 915 and 916 as well and 917. So from 913 to 917.
No, I want the affidavit from Altas Janse van Rensburg. This is just an email. I want the affidavit where you say that even your legal representative confirms that you were not given the opportunity to refer this to an orthopedic surgeon, which is the evidence you gave earlier.
Unfortunately, I mean, whatever he has provided, I've emailed through to the investigative panel.
No.
I can still obtain that affidavit from him.
No, Dr. Megan. I asked, you said in your evidence that even your lawyer has confirmed that you were never given a chance. The problem is that there is inconsistent evidence on the record with what you have said. We have to get to the bottom of this issue.
Right.
You told me when I asked you the question that even your lawyer confirms on affidavit that you were never given a chance to refer this to an orthopedic surgeon. I asked you, where's the affidavit? You've referred me to an email. Now I ask you for the affidavit. You're telling me that the affidavit is not here, you will get it.
I'm sorry, I may have used the word, I apologize for that. I may have used the word affidavit incorrectly. It said it's the correspondence. That's
All right,
the
show me
correct
where in that letter then does it say you were not given a chance to refer this to an orthopedic surgeon?
No, I don't think he's mentioned that, but I mean, but in our discussions with my legal team and myself, we had not received any communication from Discovery apart from the letter to clawback. I don't know.
One of the other issues with the code, sorry, we hear you, you say you didn't get this. One of the issues with the codes was also claiming for assistant fees when no assistant was present in this during the surgery. What's your response to that?
Yeah, we discussed this at the meeting in Discovery, and in my records, in my theatre notes, the assistant surgeon was present. Now, I'm not sure why the hospital, remember at the hospital that we're in, 60 to 80% of nurses are volunteers, are not permanent staff. I cannot, under oaths, mention why it was not documented at the time. I have no reason why.
So you're saying that your theatre notes record an assistant as being present,
Absolutely.
but the hospital's notes don't.
Don't.
And that yours is correct and theirs is not.
Well, I can't answer. I can only have what I have documented at the time, that the assistant surgeon was present. I understand that, but there's lots of issues to be discussed. That's one aspect.
Yes, I think you should take us through the aspects you wanted to discuss with us. Then whatever is of concern to you, and then.
Okay, so my concern was that's Discovery. My concern was with Medscheme, and if you look at the correspondence, I won't use the word affidavit again. If you look at the correspondence from my attorneys, our meeting of the 10th of May, the same day that we had our meeting with Discovery, with Medscheme was completely different. They were not cooperative and not willing to have a round-table discussion with regards to the use of codes, the type of pathologies that were present in those particular patient files. Now, if you look at Medscheme, on the other hand, they based their findings on 5 patient files. And they've managed to deduce that my billing is 70% higher than peers for the use of those particular codes based on looking at 5 patients' files. And my question is that, is it reasonable to base a billing practice or billing rhythm on just 5 patient files, where at our disposal we have hundreds and hundreds of patients who were subjected to surgical procedures which show in contrast, that there's certainly not more than 70% of the national norm. It's similar to what we've discussed previously, that you have to look at
Dr.
patients.
McGadden, can I just interrupt you? Sorry.
Right.
Can you turn to 879 of the bundle, please? As I understand, this is a document you provided us with.
That's correct.
Can you explain it to us, please?
So these are the, this is Medscheme's analysis of the 5 patient files that they chose to, they've chosen these files from their random audit. And these are the findings of 5 patients' files.
Where does it say the analysis comes from 5
It
patient
says
files?
there on page 880, analysis of 5 patients' files confirm the irregularities in billing scene.
I think the names of the patients are at 883, if I'm correct. No, probably the 884.
884,
Yeah,
yes,
that's the way it says patient file analysis.
that's correct.
Let me just understand this. I'm sure Medscheme will tell us this, if this analysis was done on 5 patient files.
Oh, this is from Medscheme, by the way. This
Yes,
is their
I understand
document.
that, but the sentence says analysis of 5 patient files confirmed the irregularities.
So it confirmed the irregularities in billing scene. They don't stipulate scene over 1,000 patients or 500 patients. You know, I've got patients' files that show that there are no such irregularities. They've in my affidavit that I submitted previously, I'd stated that they have cherry-picked 5 patient files, which showed.
Yes. No, that is the point of interest. So if you go to the patient files that they have cherry-picked,
Yes.
and let us forget about the fact that they've cherry-picked, but let's look at whether they are right in what they say. I mean, if you look at patient number 4, I mean, this thing struck me. Gunshot firearm, 5 surgical procedures, 178,000 rands paid, 2-hour surgery, billed at 88,000 rands. I mean, how do you possibly justify that?
Well, you know, I don't determine the rand value per code. These codes have their particular rand value. When I would perform an operation, the codes that the anatomical structures that have been operated are formulated with a code. The codes are then sent through to a billing bureau. It's the billing bureau that then processes the data and sends the codes off to the medical funder.
I think we must be clear about what this report says, because I'm not sure I'm understanding your evidence. Is it clear to you that the report makes use of Medscheme's data, not just your 5 patient files, to come to the view that you exhibit costs 30% higher and specialist fees 70% higher than your peer group? They're not just using the 5 patient files. They're using their claims data generally, including yours. Is that clear to you?
That's clear to me, but it's not all the codes that I've used. I mean, and if you look at orthopedic surgery.
Before we go on, I just want to be fair to Medscheme in relation to what your evidence is. So is your complaint, why are you complaining about them having cherry-picked 5 patient files? Because their answer is that they are checking whether their broader analysis is correct by looking at 5 patient files.
My question is that out of 1,000 patients, we could easily have picked 200 patients where I have below the national averages for my peers. Who the peers are, I'm not sure. Why not discuss that?
Okay, but for these 5, if we just look at this again, like my colleague said, regardless of whether they cherry-picked, in respect of these 5, it cost the scheme 841,000 rand for the 5 patients. That seems like a lot. Are you saying that that is not a lot because it was just the cost of seeing those 5 patients was 841,000?
Look, I agree. It does seem like a lot, but if you look at it on the grand scheme of things, out of 1,000 patients,
Don't go to the grand scheme and 1,000 patients. Are you saying that the 841 is justified in respect of these 5 patients when you go back and look at that file and the notes and the surgery that was performed? So you see the codes
that's correct.
and how you use the codes will inform your claim, right? And they are saying that the way you've used the codes have resulted in an inflated claim. Inflated by 70%. That's what they're saying.
And how do they determine by 70%? Would you kindly...
By looking at these 5 patient files.
70% in reference to what?
In reference to your peers or in reference
and
to...
who may they be?
What? Well, I'm not answering the questions here.
Well,
You're answering the question.
I'm just
I
want
want you
I just
to
want
explain.
I just want to understand
No.
what you're asking me here.
I'm asking you whether you are in agreement or not that 841,000 is the legitimate and appropriate amount to have charged for seeing those 5 patients.
Having looked at the pathologies at the time, I was not aware what they amount to. I basically used the codes that I had done. When I'm submitting codes, I don't have a reference to a rand or cent value. It's only the billing bureau who's got the privilege to see what each code costs. At the time when I perform an operation...
So you don't know what the rand value of the codes are. So when you submit a claim, there isn't a
No.
rand value on your claim.
No. When I don't submit claims, I submit codes to a billing bureau. The billing bureau then submits the codes to the funder. So at the time when I'm performing the operations, I'm not aware what the rand value is or what I'm performing. I have no idea. It's impossible to know with the hundreds of codes that are available what the rand and cent value is for each particular code. All I'm in control of is performing the operation and knowing what I've done within that operation. So if retrospectively, when I do get the figure at the amount being, yes, I agree, it does look exorbitant. Yes, I agree, it's a lot of money. But that's certainly up for discussion. I was not given that opportunity to discuss that.
Look, I mean, Dr. Megan, I don't understand why you say you don't know why Medscheme was saying these things, because in the letter to you, they told you why. So this all, is contained at 883 and 884. And they went into detail. It's one of the fewer cases where they go into this extent of the detail. So they tell you code 0303, 128 units was charged 125 times. And then it goes on. Code 0593 was the highest income earner for this practice, accounting for 23% of the revenue alone, whereas it is on average 6.6% of the peer groups, 2.72 million of the total 11.6 million earned in this period. Goes on. Other code issues include billing 0173/4/5 on admission to hospital, despite the procedure being an elective booked case where the patient was seen in the rooms. Use of code 0129. Nationally, this code is used in 2% of office visits, but Dr. Megan bills this at 55.6% of office consults. 188,000 rands was paid, which at least 90% is in question. Billing individual fracture codes as well as 0465 for the same fracture. They even tell you what the comparators. First, they've told you the usage of the code, and they've told you in reference to what. 884, they do the same thing. Using this tool, Dr. Megan rates as category 3, highest cost, with the specialist cost 90% higher than expected for similar cases. The higher cost is due to excessive use of codes and incorrect rates in many codes. Here's an overall event cost 30% higher than expected. The admission rate is 29% higher, and the use of pathology testing is 72% higher. which could be affected by the demographics of the practice, rural location, higher comorbidity risk, use of ICU at high case significantly lower, and length of stays are on par with the peer group. And then they give you the patients. After that, they say, what these patients are showing us is an astonishing figure of 841,000 rands, which they say is erroneously built. Then they say, due to the substantial extent of overcharging, it was deemed necessary to request a further 25 files to confirm the initial trends. So it's not as if they just acted randomly. They gave you the specific facts, they gave you exactly what the inconsistencies with the code is, and they gave you the comparator that you're complaining about. And then they said, we are using this to illustrate patterns. We want 25 extra files to look into what you are doing. So I don't follow exactly what you say they did wrong.
Advocates, they chose the 25 files. I mean, if we're going to do an assessment of
Dr. Morgan, we can't have this. You say you first complained about having chosen 5 files. Now I'm showing you that even that is wrong, because what they were looking for is actually 25, a bigger sample. Now you're also complaining about 25. So essentially you should have been left alone.
No, I mean, if their intention is to claw back, if their intention is to show that I'm an outlier, you're obviously going to choose the patient's files to verify what their intentions are. If my intention is to say that I'm an ethical biller based on a large cohort, I can produce 300 files that will prove otherwise. The question is it reasonable or not reasonable to say that my billing pattern is irregular or not? Is it reasonable if I produce 500 files to show that the pattern is regular? Does that make me an irregular biller compared to 25 files that they have chosen that will show complex pathology?
Yeah, but
You see,
the thing is that's not correct, because they do, as I understand it, but if I'm getting it wrong, please do correct me.
Right.
There are different methods they used here. One was looking at the 5 patient files,
Right.
and they said this is exorbitantly more than a norm, but let's look at more files, and so they request another 25. But as far as the codes go, it's not limited to 5. It's a greater number. They look at the codes used over a period of time, and they say to you that for code example 465, this is what, how often it's used by your peers versus you. Percentage difference is 31,
Right.
312% difference. So, but what I'm trying to say is that the codes that they're looking at here are not specific patient files, but codes that they over a period of time, and I think the period of time is January 2015 to December 2017. So it's over a 2-year period.
Right.
So it's not a small sample, in other words.
Dear Advocate, with all due respect, they've chosen a few codes. Within the realm of orthopedics, there's hundreds of codes that we use in day-to-day practice. Hundreds of codes. If you look at the highest cost to the scheme, which is spinal fusion, total joint replacement, those are the biggest costs for any orthopedic costs to any particular scheme. What are my costs? What are the use of my codes to my peers? Why was that never discussed? Now, I can tell you that when I choose a particular code, it is based on an individual's pathology. Now, out of the 300 or 400 patients that I perform arthroscopic knee surgery on patients that are immunocompromised, morbidly obese, uncontrolled diabetics, I choose to use procedures that are safe, that will benefit the patient. Why haven't I used codes that are the highest paying codes, such as a total knee replacement? What are my use of total knee replacement codes? What are my use of posterior spinal fusion codes, which are the highest paying codes? I do what's relevant to the patient.
I get the drift of you.
I've got 200 codes that I use. Why choose the codes that will show, that will be flagged across the national norm that the peers are using? Why not compare highest paying codes to my peers, to those peers in question? It was never mentioned. These codes are meant to justify their means, their audits.
I get what your response is.
I am saying that I've got 500 files that will show conservative practice, conservative patient patient treatment. And showing, according to my peers, will be far less than the national norms. What happens to those codes? What happens to those patients, the 600, 700, 1,000 patients that are far below the national norms? What happens to those? Why don't Medscheme put those codes in their analysis?
Sure. Sorry, I've taken
Now,
you off
yes. So
if you could just then get back to
before
what
we
your
conclude, there's an
concerns were.
important matter that I wanted to discuss today. That's unfortunately my legal correspondence did allude to, but I omitted to submit in my affidavit. And that is the meeting on the 1st of November 2017 with GEMS Medical Aid. Now, even though you may not have the details
Sorry,
of this.
Dr. Megan, are you finished with Medscheme and Discovery?
No, I haven't finished yet, but I think it's pertinent to discuss, to add reference to what Advocate Hassim is asking me regarding the use of these codes. Now remember, in my practice, based in a rural area.
Just conclude then your submissions on Medscheme,
Okay,
and then you can move on to GEMS.
all right. Is there anything
And
more?
Dr. Magan, also
Yeah.
please be aware that we have heard evidence on coding in your speciality previously, so we do know some of this.
Thank you very much. I'd want to move on to the meeting with GEMS Medical Aid. Remember, in my practice, Advocate Hassim, 60 to 70% of my practice is GEMS Medical Aid. Okay? Discovery and Medscheme form a small 20 to 25% of the patients I'd attended in the 7 years based in the rural Transkei, in the rural Ciskei. GEMS were a vast majority, 70% of my patients. Now, if you look at the meeting I had on the 1st of November with 2017 GEMS, and the reason for having that meeting was to discuss my outlier status. Okay, the meeting on the 1st of November 2017 was attended by, in attendance was Advocate Janssen van Rensburg and members of GEMS panel, was also attended by Dr. Pratt, who is Medscheme's general practitioner, who was in attendance at the meeting they had on the 5th of May. At that meeting with GEMS Medical Aid, we discussed the same issues we're discussing now, Advocate. We discussed the geographical distribution of my patient. We discussed the socioeconomic challenges of my patients. Why is it that GEMS, with the same medical advisor, gave the practice a clean bill of health, approved of what I was doing, thanked me for the service that I was providing to an area of need, yet the same medical advisor in a smaller medical scheme takes the complete contrasting stance? The meeting with GEMS was amicably concluded. They understood that my conservative means to practice was well appreciated, that they've noticed that I saved the scheme lots of money, and was happy that the way I practiced. They had showed in their graphs that in most circumstances, I was far less than the national norms. Yet for the codes that Medscheme choose to highlight, I'm 70% higher. For patients of similar pathology, in a similar socioeconomic geographical area. So if you look at the details of GEMS' outcome of their meeting, that should be held in contrast to Medscheme's meetings, which was completely different. Medscheme was hostile, uncooperative, and not willing to listen to me. Their modus operandi was that of to be punitive, to suspend my account, and to this date, I have not stopped seeing Medscheme patients. I still see them, yet I don't bill for those operations, neither do the schemes reimburse their members. Currently, no one gets paid for those particular operations. I've been doing hundreds of operations without being reimbursed, neither did the members get reimbursed by Medscheme. And that's currently to practice.
I don't remember reading the GEMS correspondence.
I did not submit it. That's why I mentioned in my opening line that I omitted to submit that correspondence. But I can certainly retrieve that and have that email through to you.
Please do so.
Dr. Magan, sorry, what is your evidence in relation to GEMS that they had no issues at all?
That GEMS perfectly understood the reasons for me being an outlier. it shows that in use of coding, that there were vast amount of codes that I fell below the national norm.
An outline in relation to what? They understood that you were
In,
in relation to the coding?
no, in terms of the number of operations performed, of the pathologies being identified and the codes relating to those pathologies.
So did GEMS have any issues with your billing?
Absolutely not. Absolutely not. Well,
Mr. Magan, can I then take you to page 913, please? This is the letter from your lawyer to yourself.
all right.
Turn over to the next page at 914, and if you could read the third paragraph down.
They undertook to revert to us to specific issues.
The third paragraph down, beginning with the word according to GEMS.
So on page 914. According to GEMS, there were not any issues with the patient outcomes, only with the billing. So to highlight that, they were inquiring on the type of codes used and the type of billing. But after my explanation, they were happy with the explanation offered, and the doctor present at the time was Dr. Pratt, who did not raise any objections. Yet he is the same doctor that represents Medscheme, that was present at Medscheme's meeting.
So it's actually not true that GEMS had no issues with your billing.
I wouldn't say issues, they had raised concern. That's why they wanted to meet in person to allow me a chance to discuss.
All right. I think you should wrap up because we interposed you in the place of another witness. So, but I don't want to pressure you. If there are important things you want to raise, feel free.
Yeah. The important things I would like to raise is that currently, I never had a contract signed with Medscheme or Discovery. I was not a contracted member. The only relationship I have is with my patients. Currently, it's been 2 years in the standing that my account with Medscheme has been suspended. Yet, the impact on my practice is such that I have not failed in my duty to offer emergent and semi-emergent care to my patients, irrespective of what fund they were, irrespective of the type of funding that they had, either in the basis of coming to my rooms or via casualty or the hospital. So to date, Medscheme chooses not to pay the member, and neither do they choose to pay me. Upon asking members to contact their medical aid upon giving them the codes of services rendered, they were told that they have to pay the specialist upfront in cash first, or pay the specialist, show the proof of payment, and then go back to the funder to get reimbursed. And I think, and in conjunction with, or in reference to my legal advisor, this is certainly unlawful, where a paying member has to pay for an operation or a service, then go back to a funder to be reimbursed. My understanding is that as an indirect payment method, you either pay the specialist in good faith or you pay the member. In this particular case, or in my case, my patients or members are not being paid, neither am I being paid for services rendering for the last 2.5 years now. So I still fulfill my duties of providing care to my patients. My patients are greatly indebted to the work that I've done. The Health Professional Council will verify that they've not received any complaints from patients or from anyone, for any other body for that matter, regarding the work I've been doing for the last 7 years. My question is that if I choose an indirect method with Medscheme, and that's purely by choice as a proprietor of my own business, surely that they ought to pay their members. Why should members be subjected to paying a specialist upfront before they are reimbursed by a funder? And I've been told that's simply unlawful. So currently we've got over 2 years of complex, semi-complex, elective operations performed with Medscheme that have not been funded. Neither have the members been refunded, neither have I been refunded or funded for those particular patients.
How much are they withholding for the services rendered?
I'm not aware. I'm not aware of the amount, but my billing bureau will certainly note those figures. I'm not aware. It's accumulated over a period of 2 years now. I'm not aware of it. Even though that the codes, I have no control on which codes that the Medscheme will choose to pay or choose not to pay, but I have not made my patients liable for the services that I've rendered. I have not put pressure on them to pay me. I've simply asked them to contact their medical aid and deemed that they should be refunded for services that have been rendered to them. I've also made mention to my patients that if they feel that I'm not deserving of that particular money, then so be it. But I have not raised any objection from not a single member for the thousands of patients that I've treated that were not satisfied for the service that I've rendered. So that is the question that I would like to use as a platform, is that if Medscheme chooses an indirect form of payment, which they've chosen in the last correspondence to me, why are they not paying their members? I don't mind that they don't pay me, and there are reasons to do that. We can agree to disagree, but pay their members. The second thing that I would like to make mention is that currently the use of coding and whenever we engage with Medscheme or Discovery would always revert us back to, please inform your association. Please get your association to guide you with the coding. And currently, as an orthopedic surgeon board certified in this country, there is no platform to guide surgeons on coding. It does not exist in this country. That means it is left to the discretion of the attending doctor on the use of coding. It is left to an open platform with the funders, with your regulatory bodies and the service providers to engage in meaningful discussion on the type of codes to be used. If after year one of practice, if an association or a regulatory body had told me, Dr. Muggin, if you are fixing a femur, these are the acceptable codes, surely I would comply. If someone tells me, Dr. Muggin, these are the codes you are allowed to bill, if anything more, please ask your members to be liable for the payments, surely I would do that. But there isn't any current platform in this country that guides surgeons, that regulates surgeons on the type of coding used. The only thing that is used to guide a surgeon is the pathology being identified, is the type of operation that's being performed. And I can tell you, by analyzing my peers that are surgeons in private practice throughout the country that transcends all racial groups, my choice of coding is no different from their choice of coding. The only difference is the volume of patients being operated by me in an outlying area versus a surgeon who's working in Pretoria, Johannesburg, who has 10 other orthopedic surgeons under one roof. I happen to be the only orthopedic surgeon in a 500-kilometer radius.
No, we are appreciative of that. I presume that marks the end of your presentation and testimony.
My final statement is request is an open platform to discuss if there are billing errors being done in the past. Why not have an open? I'm happy to sit at any open forum to discuss that. If there are errors being done, be guided as to what needs to be guided. Because I'm still a young surgeon, I'm still supplying an area of need. I'm only 42 years old. God willing, there'll be another 20 years of practice in this country where I choose to run my practice ethically and run my practice governed by the various regularities, but certainly to be engaged in in regulatory bodies that are meaningful and non-prejudiced. In my experience, I have not had the privilege of sitting in a roundtable discussion without prejudice. They've all been prejudiced. The things that I would like to be discussed is that the monies that have been clawed back, if you are being incentivized or your income is based on commission on money that is clawed back, surely your modus operandi is to claw back as much as money as possible. Up to this date, I've been investigated by a nurse or GP or a lawyer, but no one has investigated their earnings. Where are their bank accounts? I get to be scrutinized on how much I earn per minute. As a specialist surgeon, who gets to scrutinize their earnings as an ex-nurse, a self-proclaimed forensic investigator, a self-proclaimed coding specialist? Where are their bank accounts? How much have they earned? How much they have been incentivized to claw back? How much have they been incentivized to call it fraud, waste, and abuse? When you group fraud, waste, and abuse together, I think it's terribly unfair. If you say I'm committing fraud, I have every patient, a human being, that has been brought to an operating table. No fictitious patients were ever manufactured. No unnecessary operations were performed. Here we are contesting the use of coding. Whether that contributes to fraud and waste, I do not know. If that defines fraud, then I'm yet to be corrected. When it regards to waste and abuse, how does that constitute abuse? Abuse by who? Abuse by a funder who chooses to cherry pick codes, chooses to claw back money. What is the incentive for doing that? How does that impact on the rising cost of submissions from our people on a year-to-year basis? If you claim to have 15 billion rands in reserve every year, why don't our members benefit from that? People in rural areas, people that we serve, people that we have a relationship with. Our funders choose carefully not to come to areas of neglect, not to come to areas of need, but to sit in offices such as these and to make decisions, harsh decisions, some of them, on people working on the ground, providing our best to areas of need. I served a population of 4 million people that no South African chose to go before, with daily water cuts, daily electricity cuts to serve people. I studied at the University of Transkei. Advocate knows what it's like to be at that university. It is a difficult area to work in. Yet I've subjected to harsh amounts of criticism, harsh analysis for patients' work done to people who are greatly indebted to the work that I provided. All I ask for is a platform to be fairly assessed, a platform to be guided, a platform to assist each other going forward to the future.
Thank you.
Thank you very much.
I have no doubt people who are aware of that have listened to what you're saying, and people who can help will take that into account. Thank you. If there are further questions, especially the GEMS correspondence that you spoke about, if you could please send that to the...
I certainly will do that.
Yes, to the CMS. Thank you. I think we should not adjourn. We should just carry on to the next witness. Will we just exchange the sitting arrangement? Dr. Kalanda, will you come to the front, please?
Nothing was changed.
No, thank you. You just, when you refer to the documents, can you please refer these numbers and not the ones?
Which number here? What was
No, the ones in
one?
Turkey, yeah. Because the panel has the same as that one.
Dr. Kalanda, we are reinstating your evidence. We had interposed Dr. Megan, so you can commence pretty much where you left it before the adjournment.
I was at page 15.
Dr. Kalanda, can you please put your mic on when you speak? Thanks.
I was saying that I was at page 15, invite letter.
Yes.
Yes, I received an invitation from the Kubeka Forensic Services. And the attachment was asking me that for, no, I think they've, okay. Yeah. It was on 8 May 2018. So they were asking me to go to their offices because they've uncovered certain discrepancies in my accounts. And they wanted to talk to me about that. In my reply, I was asking them to forward me the account so that I can prepare for that meeting. While I was waiting for the reply, then the reply came back on 7 June. And they were saying that we are mandated by Bonitas Medical Fund to conduct data analysis and auditing. This is for audit purposes to ensure that Bonitas members are satisfied with the services you have rendered them. So it's completely different stories from the previous one, where they were talking about my accounts. And the auditor have chosen a random radiologist in the area, and your profile was one of them. Then I started questioning myself, what type of profile? We are hereby requesting, we hereby request for your patient files on the attached sample list to enable us to complete our analysis. So it was from a forensic and criminal investigation. Then because of those discrepancies, I just declined. And I told them that I was not available for that and that they could select another radiologist in the area to conduct their study. After that, on 4 June, I received a radiology profile from Polmed. They were profiling my practice. After reading the document, I realized that they were saying that I was claiming more than my peers. So I don't know which peer they compare me with. And there were false allegations inside the document. They are claiming that they pay me 111 rand for MRI, which I don't have an MRI in my practice, so I never claimed for MRI. 2,969 rand for angiography. I don't have an angiography. So I just stopped there and considered that the document was cooked. They were looking for something. And when I look at the document, the heading on the last pages, it's empty. And on the heading, they say that for your top magnetic resonance image, your practice claim more than peer. So they've prepared already just to fill up. If I had an MRI, they were just going to fill up that I claim maybe 100% more than my peer.
Dr. Kalanda, sorry, what page are you on now?
On the radiology profile, the last page, 37. It's just an empty chart, it's just ready to be filled with numbers and tables.
And can you explain your interpretation of that?
My interpretation on that is in my letter. I said that I've received your email and I don't agree with its content. It must be clear and understood that I am not Polmed Medical Scheme employee.
What page are you reading from?
24. and my radiology practice is not working for PolMed medical scheme. As far as I'm concerned, I don't have any contractual issue with you. We never agreed on table of tariff on how I must charge. My practice has never introduced a claim for MRI, this one I just, and even the total amounts of my practice claim to PolMed medical scheme for year 2018 does not correspond with the amount in your profiling. And my practice perform radiological investigation only on referred patient when there is indication. So this is what, in summary, what I was telling them. It was on 4 June 2019. Then we go to page 38. I received a letter from on 10 June 2019 from Medscheme. It was Medscheme and Bonitas, telling me that a routine verification visit in order to verify service rendered by your practice has been conducted on 5 June. It is unfortunate that what's happened is that I was in my office and my receptionist called me and told me that there are 5 people here, I think 4 or 5 people, they want to see you. Then I went to see them. They said, no, they told me that they are from Medscheme. They want to see my equipment. I was surprised because I didn't have any appointment with them. And they didn't even provide me with any document to prove that they are from Medscheme. I told them, look, I don't have a problem, but I'll give you one condition. This one I didn't write in the letter. There are other white practices here. Go and see the equipment, and then when you come back from there, you come to me. I'll phone them and find out if you went to see the equipment, and then I'll show you my equipment. These are my conditions. They left. And they went to another black practice to check for equipment. Because the colleague phoned me and asked me, did you receive a visit of? I said, yes, they came, but I didn't show them my equipment. So after that, I received this letter that as a result of that, the payment to your practice has been suspended and a full audit has become necessary to verify your claims. Then on page 41, I'm giving them my reply, telling them what I've told you now, that I received for individual, and I refuse to give them access to my equipment. And the fact that they are suspending my payment, I will continue to see my patient as usual. And then I will send my claim to them and wait for payment within 30 days. If not, I'll ask the patient to come and settle, and the difficult case will be over to debt collector, and I'm asking them if it's what they want for their members. I received a reply on 14 June. They wish to advise me that a direct payment to my practice is terminated. It's page 46. And it will be effective from 18 June 2019. And they are stating that all accounts for your service must be settled by the patient and then submitted by our member, so they will pay back, they will refund the members.
Dr. Kalender, referring to that letter from Medscheme,
Yeah, page 46.
46,
Yeah.
what do you know about their review of your claiming patterns and profile?
Oh, we are going there.
We're going there, great.
Yeah, this is before we get there.
But at this stage, what
This
do you
stage,
know?
they were not reviewed yet.
Okay, so at this stage you know nothing?
No, nothing. There's no review pattern. You see, first, 2016, they said that there are irregularities. They send me the audit. I reply, I ask the lady, is it, why are you doing this? She said, okay, give us your document. Then I give, and nothing, no irregularities. 2009, I think it's 2008, if I can remember, again, irregularities. I asked them which irregularities. No, it's not irregularity. We just want to do audit to check if our members are satisfied. So I understood that irregularity for them is a generic word. Whenever they want to access somewhere, they say, okay, we've encountered some irregularity. But when you ask them which irregularity, they don't have anything. So they must access your file to try to dig up and find something. So at 40, I think page 46, they say that they will no longer pay me and they will pay patients. On my reply, I tell them, I've received your letter. I feel like I'm bullied and racially profiled by your medical scheme. In my eyes, your decision to suspend my payment to my practice does not seem based on valid reason, because they didn't give me a valid reason that they're suspending my payment. And I dispute it, and I told them I'm available to discuss and try to settle any misunderstanding. Page 48. They acknowledged receipt of my letter and said that they will come back to me. They came back to me and we had a telephone conversation. During that telephone conversation, I think after that, then they decided to do an audit. Because I'm complying, I don't have anything to hide. I say, okay, I don't have a problem. You can do your audit. So they were saying, in page 50, the audit will start from January 2017 up to 10 June 2019. Verification of services. So they were giving me a list of patients for which they wanted a file. They wanted to have a clear list of equipment, including licenses, but I gave them my licenses in 2016. They want it again. They want a list of all employees employed in my practice, including the practice numbers. I provided them with information, page 53. Then, 15 August 2019, after the audits, that's when they start with their problems. So, following the audit, they have said that they found some irregularities, especially with unbundling of ultrasound codes. Because of those irregularities, there is a certain amount that I should pay back to them, page 59. And if I don't pay them, they give me an option, repayment agreement by way of an agreed payment arrangement over fixed periods, settlement by means of a deposit of the entire amount owed, 3, by means of direct deduction from future current valid claims submitted by my practice. If I don't agree, they reserve the right to report me to Credit Bureau for blacklisting or for blacklisting. In fact, what are they saying? When I do ultrasound, I have a request for ultrasound from the referring physician. The referring physician wants an ultrasound of abdomen and pelvis. The abdomen starts here and ends here, and the pelvis starts here below. Then I examine the abdomen and pelvis. Then I claim the abdomen and pelvis. But the medical aid has made a provision where they've bind those two codes, the abdomen and pelvis, they've bind it into one. to make it cheaper for them. It become abdomen including pelvis. So this is the code that they want me to use. So because I've not used that code, all the they've now tried to calculate from the audit that they've done, all the difference amounts I owe them. And if I don't pay, they will blacklist me.
Why do you believe that your method of coding, which separates the two, why do you believe that is the accurate method versus the scheme that says the two should be bundled?
I'm doing what the referring physician asked me to do. I don't know how to explain it. You go to a shop, either a car dealer, you want a bakkie and a sedan. And the guy gives you a double cab. I don't know. He said, oh, it's cheaper to have a double cab, but you want a bakkie and a sedan. So the referring physician, I've given them all the request form and my reports for the audits. And the referring physician, the referring physician is requesting the ultrasound of abdomen and ultrasound of pelvis. So they must talk to the referring physician, tell him, please referring according to the code that we want. Don't request like that.
Sorry, Dr. I think we are at cross purposes.
Yeah.
Because what I'm trying to explore is whether there is an inconsistency between the job that must be done from a clinician's point of view and the function of the scheme, which is reimbursement. Because you are saying that from a medical point of view, you have to separate them clinically. The scheme says for purposes of billing, they must be combined. That is what I'm trying to explore with you. You're saying that the real problem is that the schemes do not care about what we must do from a clinician's point of view.
This combining is just for money purpose. The scheme want to save money. That's the main issue, is that the scheme want to save money. That's the main issue.
And the dilemma is the scheme will argue you want to make money.
I'm in business. I'm serving the people, but not only do I want to make money, I'm the one who decide what I will do. There are people who are working free from my practice. I look at him, I say, this one I'm doing for free. It's not irregular. This one, I just tell my staff, please don't claim for that guy, just let him go. It's my decision. It's not the medical scheme decision. So it doesn't become irregular for that. Because actually they want to impose on me, which I don't accept. So in 61, I'm telling them that I'm accountable for all code that I've used, all claim and
Dr.
all.
Kalanda, sorry, can I just read the scheme has given a response, as you know, to your complaint.
Yeah, I'm going to there.
Will you take
you
us?
want us to go straight to?
No, it relates
Yeah.
to the same point. So
Yeah.
I don't want. I'm not asking you to jump around. Your
Yeah.
chronology is fantastic.
Yeah.
Are you aware of the email that the scheme has, Medscheme has put up from Dr. Richard Tuff?
I'm aware of
Okay,
it.
so you'll come to that.
Yeah,
Thank you.
I'm aware of it. So now, I'm telling them that I'm not owing them money. If they want to take me to credit bureau, they can go ahead. But I will sue them for loss and damage. But at the end, I'm telling them, look, I'm available to discuss and harmonize with you of any change you wish for the future of our relation. So I'm making myself available to talk to them, to negotiate, to see where we can meet and how we can move forward.
Before you carry on, I just need to ask one other question about this letter from Medscheme to yourself when they suggest the amounts that you should pay back. So at page 58, and we obviously have to test if Medscheme is being fair. They say to you, patient records requested were received and a number of billing irregularities were identified. At that time, did you know what these billing irregularities were?
Yeah, that's a problem with Medscheme. They use the term irregularity, This is the only irregularity that they came with, is that one, the unbundling of codes. Except for that, they didn't come with something else.
And do you know how that amount of 170,281 rands was calculated?
Yeah, that's what I was explaining before. They took all the claim that I've done for abdomen and pelvis. They make it as whole abdomen including pelvis, and the difference amount is what they are saying that they're claiming that I owe them.
Okay, I thought that amount was the 169 below, so that's why because that relates to the abdomen and pelvis issue.
Yeah.
So that's why I'm asking about the 170,000.
I didn't really, what I'm doing here, I'm not going into detail into the amount. I'm just going into the principle first. I'll look at the amount later. I'm going on the principle. Is there any irregularity or not? That's the principle that I'm working on. Because the amounts, I'm not looking at the amount. I'm looking first, is there irregularity? Because I'm telling them there is no irregularity in what I've done, so you have nothing to claim from me. That's where we are fighting now.
Go ahead.
So, and I give them my email and my phone number so that we can talk and discuss. But if they go on, carry on with credit bureau, I don't have a problem with that. I'll take them to task. Then, because of that, I've shown them that I'm willing to negotiate, I'm willing to talk to them, but they're not showing any willingness. Then I introduce my complaint to the medical scheme. In that complaint, I was talking about the bullying tactic, the letter of invitation from a criminal investigator, the radiology profile, cooking of documents, sending unidentified people in my practice just to want to check. Why are they doing that? Because of my profile. Unlawful suspension of payment to my practice, because they didn't give me a valid reason when they suspended. This unbundling of codes problem came only after the audit. Imposition of tariff code to use, and attempt to extort money from my practice. So that was my complaint for. And my expectation was asking them to stop bullying me and to cancel the unlawful suspension of payment and to stop cooking documents and to contact me or my practice directly and immediately if they identify any specific billing anomaly or error. And they must be specific about it in order to provide me with the opportunity to verify allegation and give an appropriate response, page 70. And to stop any attempt to extort money from me. Then we had another telephone conversation after that, because I told them that I was available. Page 71. They informed me that there was some missing from the previous audit. There were some documents that they didn't receive. And I asked them to forward me the list. And I give them, again, those information. So they received all the information they needed for the audit. And page 73, they come with something else. They continue again with this irregular ultrasound code billing, but this time they are not threatening to take me to credit bureau. They say that they will just collect money from the money that they owe me. Page 74. Page Page 74, the last paragraph. Please be advised that the quantification for irregular billing will be recovered by means of direct deduction from future current valid claims submitted by your practice. Then after that, I reply to them because they have been in breach of their own letter first, because they were suspending my payment on 18 June. But in fact, they have stopped paying before 18 June. Page 76. Then I provided them with a list of patients for whom I didn't receive payment before 18 June, because according to their letter, they say we will suspend your payment effective from 18 June. So they were in breach of their own letter. Secondly, they were in breach of the Section 59 of the medical scheme, which gives them 30 days to pay claims after receiving, to pay a provider or member after receiving claims, irrespective of what. And I also I tell them that I will no longer talk to them, and I will wait for the, I inform them that I've lodged a complaint against them and that I'm no longer available for discussion. So that's where we are with them. So with regard to page 84, no. What you are referring to about, yeah, page 86. First, I think I've given you a document, page 87. Practice are reminded that, as in the past, it is their prerogative to determine their own billing rates. After reading this letter on 86, I've contacted the Radiology Society to ask them if they can give me a guideline on how we should claim. While I was here, I received some reply. I tried to go through it, but it was not talking about the issue at hand. That is one. And I don't know what the medical aids ask the Radiology Society. I don't have the correspondences. I have only this answer. But he's saying the underlying principle of the RSA coding structure is that wherever possible, then it means that it's a discretion of the radiologist who doing the person who's doing the investigation. So, on my side, I think there is no irregularity on my billing. They are just trying to force my hands to admit that there is an irregularity. I told them that there is no irregularity. And for that, I'm not owing them any money. So we are at that stage. And they didn't pay, even some members didn't receive money from them. Some of their members.
I mean, I don't think that the case made by Medscheme is that you've done anything dishonest. I think there is a problem about unbundling.
Yeah.
That is the main complaint they have against you. Now, someone needs to set the rules about the bundling or unbundling of codes. You've given us this document from the Radiological Society of South Africa, which on the face of it seems to say it's your prerogative to decide your code. But the scheme sets its codes, which you are aware of and you've signed and you've agreed to them. Why don't you comply with them?
I didn't sign anything with the scheme. My customer are, my patients, those are the person I'm dealing with. The scheme is with his patient, and me, I'm with my patient. So I'm claiming because the patient tells me, look, this is my medical aid, but I didn't sign anything with the scheme. I don't have any contractual obligation with the scheme. And I'm not working for the scheme.
I'm saying, why don't you just comply with what the scheme says? What's the problem?
Because I'm not working for them. I'm not their employee, and, you know, I think I've shown them that I'm willing to talk to them. What does it mean? They can come and negotiate with me and tell me, look, doctor, we would like it to be done this way. It's costing us, we need to save some money for our shareholders. Can you please help us in that way? But they don't do that. They're just coming to force me. I cannot accept that.
And I mean, part of the problem, of course, is that this is all retrospective.
Yeah.
And this doesn't seem to have been any notice before that you couldn't unbundle.
No, I'm doing, you know, they have, if you, because what I want to say, the specific cases that they have selected are the cases from oncologists. Those are patients with cancer. And cancer, it spreads all over the body. That is why that specific oncologist is requesting abdomen and pelvis, because he knows, he knows that cancer in the brain, you can see something down there. So it's a general checkup. So there are cases where I'd use the unbundled code, but it's up to me. It's not up to the medical aid. It's up to me.
Just to make sure I understand that, I mean, is there anything clinically that would be wrong if you used the codes that the scheme suggests you use? In other words, the bundled code.
There is nothing really clinically that will, there's nothing clinically, but the amount of work. The amount of work, the work and time.
Isn't it less work if you're doing a pelvic and abdomen scan at the same time than if you were doing them separately?
No, it will be same work, but more time.
If you're doing it
More time,
in
like
one go.
like I do the abdomen, the patient goes out, then come back for a pelvis.
So it would take more time to do a separate pelvic scan and a separate abdomen scan, right, than it would to do both on one patient in one go.
You know, as I'm telling you, this patient is an oncology patient, which means he's a patient with cancer. There are many small details that we are looking at. Unlike someone who can look, I have pain. So the attention, the energy is different.
But in general, if you were to do a pelvic scan separate from an abdomen scan, that would take a bit more work and time than if you were doing them together on the same patient.
On the same patient together, it will not take, it depends on the experience. Me, it takes me around 15 minutes, 15 to 20 minutes for abdomen and pelvis. I don't understand.
My point is that it would be, because it is less complicated, to use a simple word, it takes less time, it's less complicated. It's not two separate patients or one patient, but it's seen on 2 different days and 2 different scans, that it is appropriate to use the bundled code.
No,
Because if you use the unbundled code, you're suggesting that there are 2 separate scans that have been done, which costs more.
Yeah. You see, they have selected a specific cases for their audit. And those specific cases are patients with cancer. And patient with cancer, even a cancer of the breast, it can spread in different organs. So we are staging. So I have to check small details and not miss them. That is why.
That's what I'm trying to
I'm
test.
charging also for this energy that I am. It's a lot of energy.
Yes,
It's not like someone who comes with, look, I have a pain. You don't use the same attention. What I want to say, the work is not the same. It's not the same work, depending on the clinical indication.
Yes. Now, that's, earlier I was asking you if your testimony to be understood is that the bone of contention between you and the scheme, that you're saying you have to do it your way because that is a clinical judgment, which is in the interest of the patient. In other words, you must unbundle the two procedures.
Yeah.
From a clinical point of view. And
Yeah.
then you said, no, you don't have to do it from there's nothing clinical about what you're doing, it's just a choice.
I don't get it well.
But I mean, you could have chosen to do it the way the scheme wants, you just don't want to.
I'm doing it. It doesn't mean that in my practice I don't charge the unbundled one. I do it. I use that code. But the specific patients that they used for that study are patients with unbundled codes. And those patients, clinically, those are patients with cancer. So it requires from me more energy to check. Unlike the other one which I'm using the unbundled, which, like, you have some healthy patients, just some pains, the indication is not the same. Then, from the energy that I am spending and the time, I'm selecting those codes because also, this is what the physician requested. The physician requested me to do an abdomen ultrasound and pelvis ultrasound. So I'm giving him what he asked me to do.
Show me where you told the scheme, those two explanations you've given, that firstly, these are oncology patients, and secondly, it was an instruction from the physician.
Yeah, I didn't tell them that these are oncology patients because I just realized it when I was doing collecting the data for them. I realized, but these are the oncology patients that they are requesting, because oncology patients are the most expensive. When the doctor for oncology requests a CT scan, he doesn't want, he requests sometimes from the head still there. Those are the most expensive. So they select the most expensive investigation because it's costing them, and they say, let's verify. But these are patients, most of them, all of them, those are oncology patients that they have verified. So if they have selected other patients, they will see that I'm also using the abandoned code. But the point here is that there is no irregularity.
Can I ask a question about these
Yeah.
codes? Do each of the codes, so the 43200, 41200, 40210, do they each have an associated time?
Yeah, because they have a limitation. If, for example, I say ultrasound of the abdomen, then I limit here. I examine this area.
Does the
Before-
code have, like psychologists,
there
is there time? Does it take you 10 minutes? Does it take
No,
you 5?
there's no time. The time depends on each one with his experience. There is no the time frame for your investigation. Someone can take 1 hour when someone can take 10 minutes, and someone can. So it depends on the individual. But yeah.
Thank you. Do you have anything else to add?
No, I don't have anything else to add.
All right. Well, thank you then for your time and for coming.
Thanks a lot.
If there are further questions, they will be sent to you in writing.
Okay, thanks.
The inquiry is adjourned until further notice.